Well, thank you very much for inviting me to come to this course here in London, and I'm very happy to speak here. And the first topic I'm going to talk about is not the benign one, but the malignant ones. Sorry. Malignant focal liver lesions, mainly, of course, understood as metastasis. So our diagnostic goals that we have with these malignancies is number one, it's detection. Number two, characterization, as you just heard from David. So a differentiation from benign lesions, of course. Number one, the type of tumor we can very often characterize, and the vascular supply, important for interventions. And then, of course, follow-up under chemotherapy or immune modulating therapy, ablation therapy, surgery, or spontaneous cause of disease. So, of course, it's also important at that point that we have to look at the techniques that we are using to image contrast agents. So here are different ones, and you heard already in the first talk that we have two major techniques. Number one is amplitude modulation imaging technique, AMI, that has the advantage of penetrating very well and very deep into the liver. That is the advantage. The disadvantage is it has some kind of blooming. So the temporal resolution the spatial resolution is not as good as in the technique that was used previously. That is the pulse invasion imaging technique, and that has very good and up to now the best, nearly the best spatial resolution. Tissue suppression is not as good as an amplitude modulation technique. And then we have new ones. The one that I'm showing lots of images of is these low MI harmonic imaging mode. We named that high rank, and I developed that in December 2009, and that was thrilling. I showed you the very first loop of this technique. And then, of course, we have B-flow that is patented by GE, but I learned that also, of course, Toshiba has a similar technique, and I think both techniques can be used for using contrast. So the advantage of B-flow and contrast is that it has the best in-class tissue suppression. But of course, we get no information about stationary echoes. That is very important. So the use of this technique is very limited. Okay, benign versus malignant tumors, you already heard that the benign lesions show high ISO enhancement over all contrast phases. So benign lesions are best detected on B mode, of course, number one, but also during the arterial phase. Because of the late phase, they are ISO enhancing with the surrounding tissue. So you will not detect it in the late phase. You will detect it in the arterial phase or in grayscale. So that is like FNH or hemangioma. And the malignant lesions, they wash out. Metastasis mostly during the late arterial phase or early portal venous phase. Okay, so it is important also to look at the time that is being needed for contrast to arrive in the liver. So in healthy subjects, and we looked at that, the average time for arrival of contrast in the hepatic artery is about 9 seconds, 9 to 10 seconds. The time interval before the contrast is entering the portal venous system is about 3 seconds. So we have 3 seconds time to image the complete arterial tree. That is not very much, but we can do that. Number two is after the contrast arrives in the portal vein, it takes some time until you can see the first bubbles appearing in the hepatic veins. So that is round about to 21 seconds. So it is important to have these numbers in mind when we look at lesions and their contrast behavior. The next question is, of course, what is the reason why we see differences in tumor enhancement between benign and malignant and among malignant lesions? Number one is, as you all know, probably, we have tumor vessels that are leaky. And the leakiness of tumor vessels is important because as soon as fluid is being pressed out into the interstitium of the tumor, then the pressure in the tumor is rising. And due to the rise of interstitial pressure, then the number of vessels entering a tumor, especially in the center of the tumor, is going down. So that is one of the reasons why chemotherapy does not reach all the viable but ischemic areas of a tumor. Number two, that causes, of course, tumor ischemia and necrosis. And we have, that is also a characteristic thing about malignant tumors, we have a very high microvascular density. They can make up to 10% of the weight of a malignant tumor. Shunting is also very common, either within the tumor or even shunting that will cause changes in the surrounding tissue. And then we have a high density of tumor cells. That's also important when we look at tumors. And it's always a good idea to go to the pathologist and have a look at the microscope. How do these tumors look like? How big are the tumor cells in comparison to the hepatocytes? And you will find out that, for example, in non-Hodgkin lymphomas, the tumor cells are much, much smaller than the hepatocytes, but much more densely packed. And this results in a washout by the late arterial or during the portal venous phase. Of course, as you just heard by David, that we don't have these sinusoids in malignant tumors. That are, of course, correct. But also in hemangiomas, we have no sinusoids, and they also do not wash out. So we have to look very carefully at the vasculature of tumors. Contrast characteristics of metastatic liver lesions. Number one, the tumor-related changes of the contrast kinetics. Number one, we have the arrival time. In some tumors, the contrast arrives very early, before the arrival in the liver parenchyma. And then we have a change in the transit time. That means the time between the arrival of the contrast in the hepatic artery and portal vein and the time that is passing until you see the bubbles appearing in the liver veins. So this is mostly shortened in malignant tumors. The vessel architecture is maybe chaotic. It may show a spoken wheels sign, a basket sign, or regular branching. Sometimes you can see that in color Doppler, but mostly, of course, Sears is much more superior to these common techniques that we use to image the macrovasculature of a tumor. The flow direction, that may be interesting, and you already heard that. Centripetal or centrifugal enhancement, that is important, and we will have a look at that later. The strength and duration of enhancement is, of course, a characteristic feature. So we look if the tumor is hyper-enhancing, also hypo-enhancing. The enhancement distribution in the tumor is important. So does the tumor enhance homogeneously, or do we see areas in the tumor that are more enhanced than others? Or in other words, are there ischemic or necrotic areas in the tumor? And then we have something that we name the peritumoral enhancement. So when you look not at the tumor itself, but if you look at the effects that a tumor and the vascular situation of a tumor produces, then we will see shunting. Shunting, for example, in the periphery of a tumor. So this is not tumor, but it's an effect caused by the tumor. We see posterior enhancement, we may see shadowing. These are all effects that are being caused by the tumor itself. Detection of tumor cells. Each day I drive to my hospital, so this is in summertime. When I go to my hospital, this is a tree. But when you look at the same tree and during wintertime, you see that. So this is, of course, our goal that we have. The tumor is disguised by the leaves in this case, so we would like to see the tumor cells being separated from the surrounding liver tissue. So this is something that you can also find in the book. That you have the contrast kinetics in the tumor compared to liver tissue. You can see quite nicely that we have some tumors that enhance much earlier than the liver parenchyma and much stronger maybe also during a short or for a couple of seconds in the tumor. And then, of course, it is being washed out very quickly, and others are enhancing also prior to the liver parenchyma, but not at the same level as the one that I was just talking about. Others enhance just like the liver parenchyma, but they lose a contrast concentration quickly, and others never take up the same amount of contrast bubbles compared to the liver parenchyma. So this is the normal situation in the lab. So you look at a patient. This is a patient with rectal cancer. Can we dim down the lights, please? Oh, thank you so much. So just have a look. So this is a daily challenge. Are there any metastases? In grayscale, I must confess I didn't see anything. So I used contrast. And on the right side, you can see contrast. And what is interesting to see, if you look at segment 7, here, you see? There's an area that is hyper-enhancing. And over a couple of seconds, just 3-4 seconds, it started to wash out in the center. And then you can only see a hyper-enhancing rim around it. So this measures 8 millimeters in size. And then, of course, we can say, okay, do we really believe in that? Let's do it again. Okay, so now we have, you see now the washed out lesion quite nicely. And then we give a second injection in order to see, is it really hyper-enhanced during the arterial phase? Here it is. You can see the supplying artery. This is the tiny artery supplying this tumor. So this is something that you can see for, let's say, 3-4 seconds. But this is maybe an advantage to characterize a tumor. That is what we can do. This is the one that I was talking about. So this was an eye-opener for me. So that was late in 2009 when we said we have to find a better technique to image contrast. So this is a patient under chemotherapy with metastatic breast cancer. So we were looking at the liver and we thought, oh yes, maybe there are multiple, maybe there's only a few, but definitely there are fatty changes in this liver due to chemotherapy. So we said, let's look at contrast. And so this is what you can see now, a big metastasis, and all the tiny lesions here that do not, or that have been washed out, are metastases. So we counted, and the number was over 50 metastases. Most of them range between 3 millimeter and 6 millimeter. This is something that we can see very nicely. CT was performed on that patient, and CT saw only a handful of metastases. So I think we are much more sensitive in most cases. If we have good scanning conditions, of course, that is a must, that you can really see the liver quite nicely. So this is a colleague of mine. She's 45, had a malignant melanoma, and she was treated, partly a little resected, and then she came back, and then you can see it. Very obviously, there are lots of metastases in the liver. But of course, we also would like to know how they vascularize and what is the degree of perfusion in these metastases, because this would be an argument to say what is happening under chemotherapy or under immune modulating therapy. Is the vascularization going down, yes or no? So we need to have a basic study on contrast. So this is what we have here. And now you can see the contrast is arriving. You can see the arteries, only the arteries. And now you can see lots and lots of metastases, all hypervascularized during the early arterial phase. So this is during the first 10 seconds, you can see this metastasis. Okay, and then of course we would like to know something about the character of the lesion. Of course, what you just seen is of course a characterization of metastasis during the arterial phase. Each time that you can detect in metastasis, no matter if it's the arterial phase or the late phase, it is also a characterization of the tumor. So this is by Gary Larson. I like this cartoonist very much. So he said, this is how my Irish center looks like. The Irish center may look happy, or maybe suicidal, or something in between, unexcited or whatever, but the Irish center always looks the same. But if you could look deep into his heart or his soul, you could recognize, there are different moods, but you don't see it. So this is exactly the situation that you have in Grayscale. In Grayscale, you can never really see what is it? Is it really a malignant tumor? Is it a benign tumor? We just had this discussion. And that is, of course, important. That is why we do need contrast. I'll give you examples for that. So this is a patient with a prostate cancer. This is the only lesion that we saw. The lesion is measuring 6 millimeters in size. You can see it here. The gallbladder has been removed, and you can see the lesion, I think you can see it with the echo-poor rim and the echogenic center. And then we give contrast, and this is an accumulation mode. And in the accumulation mode, you can see very nicely that single vessels, arteries are entering the tumor, so it's being vascularized during this arterial phase. So this characterizes the tumor, and you can see they are more or less chaotic vasculature. Well, here, this is a patient with a neuroendocrine tumor. Again, this tumor measures less than 1 centimeter. And let's have a look how it is vascularized. Of course, we know that neuroendocrine tumors are hypervascularized. You can see the supplying artery. You can see the hyper-enhancement during the arterial phase. And again, what we are doing next is we use a accumulation mode, and I zoom the image. It's exactly the same. It's taken from the loop above, and this is how it looks like. And you do not only see the arteries, but you can now already see the shunts to the veins, to the portal veins. So they leave the lesions. So this is the reason for intrahepatic metastasis. Okay, so we see the veins draining the tumor. Or here's another patient with a calcified metastasis, and you can see very nicely the artery that is supplying this tumor. You can see that the tumor is taking up the contrast, and then it starts to wash out already during the arterial phase. Now the arterial phase is being defined up to 30 seconds, and now you see we have now 26, 25 seconds, and it's starting to wash out. Okay, so this is a malignant tumor, of course. This is another case with iso-enhancing tumor. The center is necrotic, as you can see here, and there's only a couple of seconds when you can see the tumor is iso-enhancing, and then it's washing out very quickly. Now you can see it's washing out nearly completely. It's only a question of seconds. Or here, of course, on grayscale, you can say, oh yeah, that's clear. This is a patient with a colon cancer, and you can see lots of metastases, but it's not so easy to define where and how many metastases are there. But if you give contrast, then you can see contrast is arriving. And then you have a couple of seconds where you can see a slightly hyper-enhancing lesions. You can see them here. You see the arteries being well defined from the portal veins that have a little bit less contrast filling. And now you can see they're washing out, and you can count them. So that is more convincing than the grayscale, I think, especially for follow-up. Okay. This is a ovarian cancer metastasis. And again, we look for the artery or the arterial enhancement. You can see that the center is again ischemic, but what you can also see is some shunting to the periphery. So this is no tumor tissue. You can see it's wedge-shaped. This is very often the case, wedge-shaped shunting. And then you can see a little bit later, completely washed out in the late phase, but still you can see some shunting effects here. This is a gastrointestinal stroma tumor, and you can see very nicely in this slightly hyper-enhancing tumor where the bubbles come from. They come from the periphery, and they enter from the periphery to the center, and the center again is ischemic. And what you can also see in the periphery, there are some satellite metastases or tumors. That is also typical for this tumor. And sometimes you have a grayscale image, and you think, clear case, it's just a cyst. So you can see this is a patient with a malignant melanoma, and then I use different modes, and then I switched to the linear probe. And on the linear probe, it was not really well round-shaped. So this is why I thought, well, let's do contrast. Let's do contrast. So this is here. This is the so-called cyst. It's not a cyst, it's a tumor. It is a metastasis from the, and it's not the only one. The next one is here, and next one is here. This one, subcapsular, measures 4 times 2 millimeters. And you can see the supplying artery of this tumor. Okay, and it's, of course, washing out quickly. Calcifications, also clear finding on grayscale ultrasound, but as soon as you have if there's a history of malignant tumor, you should perform a contrast study, because these calcifications are calcifications of the tumor. So you can see during the arterial phase a hyper-enhancement around the tumor. This here is hyper-enhancement. This is the calcification. Of course, it's not taking up contrast, but calcification is just in the center, and around it, there's a tumor. So you should take time and contrast to evaluate if this is only a calcification or if it's a calcified tumor. This is another patient who had a colon cancer, multiple metastases, and you can see here a wedge-shaped hyperenhancement of a subsegment in segment 7. And you can see it's hyperenhancing. You can see the metastasis as washed-out lesions close to this area. And this is the loop. And when we look at the loop, very careful, and we look at the 19-second image, and then 22 seconds, and this is 28 seconds. And we look, these are the arteries supplying this subsegment, and they are responsible for the hyperenhancement. And what we also see is the portal vein between is occluded because of tumor, and here as well. So this is something that we can see very nicely with contrast if we have and use a very high spatial and temporal resolution contrast setting. This is also a finding, this is also a colon cancer metastasis, and you can see very highly vascularized already on the color Doppler. And this is on the left side, the enhancement behavior of the tumor. Well, in the beginning, it starts to be, well, nearly well-defined, but then it's fading away. The contrast is being enhancing the area around the tumor. And on the right side, you can see the tumor is now washed out. So the idea was, when we saw that, well, how big is the tumor? So you can measure it as the hyperenhancement around the tumor. Does that belong to the tumor, or is it only shunting? And we think it's only shunting. We asked our pathologist after surgery, how does this tumor look like? Many metastases, satellite metastases maybe. No, not. It's a very, very well-defined tumor. So this is shunting. This is another patient also with shunting, and you can see very nicely, this is the early arterial phase where the tumor is enhancing, and then over time you can see the washout, and around the washout area is an area with hyperenhancement. Okay, so this is a patient who had a prostate cancer 4 years ago, and the urologist was looking after him, and one day he found out, oh, there is a lesion in the liver. I sent this patient to CT. CT says, yes, there is a lesion, but it's probably a benign lesion. But he recommended follow-up after half a year. So half a year later, he came back, and then the CT report said, yes, there is still the same lesion, but it has become bigger. We suggest to do a biopsy or something else to characterize this lesion. So this is why the patient was sent to my place. And yeah, this is the arterial phase. And it's a classical finding. You can see the central arteries supplying this area, and you can see arteries branching from this main artery into the tumor tissue. Okay. So we have no real neovascular, there is some neovascularization, but the major arteries are not destroyed. And you see it's starting to wash out. And if we look a little bit later, this is after 1 minute 10, it is nearly completely washed out. So this is a typical finding for non-Hodgkin lymphoma. Not all non-Hodgkin lymphomas look like that, to make that clear, but some of them do. And we biopsied this tumor. It's always interesting to go to the pathologist and have a look at it. So this is, in the center, you can see normal hepatic tissue, and around it, you see tumor cells, and this is the PAX5 stain, staining the active B lymphocytes. So this is then the diagnosis, confirmed serious diagnosis of an extranodal hepatic non-Hodgkin lymphoma. There were no other lymph nodes in this patient seen. So thank you very much for your attention. So you see, SEOS is a strong diagnostic weapon.